Good morning, folks. Welcome back. Hello, good morning. Welcome. We'll give it a minute for our numbers to tick down, and then we'll get started. Good morning. All right. Good morning. Let's get started here. I am going to begin with interpretation. I'm a little out of practice here. We've had a few weeks off. Sandra, would you mind giving us the Spanish interpretation in Spanish?
Hola, buenos días a todos. Gracias por estar aquí. Por favor, vayan a la caja de herramientas, busquen el globito, los tres puntitos donde dice M-O-R-E, More, y ahí háganle clic a el idioma español si quieren escuchar esta interpretación en español. Gracias. Back to you, Izzy.
Thank you. All right, so I've begun the interpretation. You should see language interpretation available. Click here to get started, pop up at the bottom of your screen. If everyone could click that globe and choose English or Spanish, it will put you into the proper feed. And sometimes we need to go backwards, and so it's a nice thing to do. I'm going to begin the caption. And also just let folks know that there is a new feature. And actually, I can see that I've used this feature. Hold on one second. All right, so you can now, in the new version of Zoom, which everyone please update your Zoom settings, but in the new version of Zoom, you can choose captions in the language of your preference. And so if it helps you to turn on Spanish captions, please do that. You go down into your little toolbar. I believe you click More, Captions, and there you can choose your speaking language, your caption language, other things. That's how it works for me, but I'm the host. For you, it may be slightly different. So if someone has a different experience, you could put it into the chat for everyone if you want to try that out. So that's a good thing. Okay, so good morning, everyone. Welcome back. And welcome to Early Care Connection. I'm Izzy Greenberg. Today, we have our usual resident panel of experts, Meryl Gay from the Connecticut Early Childhood Alliance, and I believe Ava is joining us, although she isn't here yet, but typically, Ava Bermuda Zimmerman from the Child Care for Connecticut's Future campaign. I'm hearing two audios. Okay, so let me work on that in just 1 minute once I get this started. But I don't know if other folks could actually put into the chat whether they're having that experience. I'll know if it's just you or if it's everyone. Anyone on the panel actually having that experience? No. Okay. It may just be you. So let's maybe Google that or go out and come back in. That might be the right way. Okay, so let's thank you to Sandra for providing interpretation this morning, and a reminder to you and me to speak slowly so that Sandra can actually get the information to all of our Spanish speakers here. So good morning. I'm seeing in the chat, Happy New Year to everyone. Reminder to use the chat for technical difficulties like the one we just had, or to communicate between the community here. So that's a good place to share information with each other. If you have questions for our panel of experts today, that is the right place for the Q&A. And you'll see that at the bottom of your screen. Okay, so reminder that we've got today, and we've got a really great topic today. I'll tell you about that in a second. Next week, we are off again, unfortunately, but fortunately, in honor of Dr. Martin Luther King's birthday, we are off, but then back again on January 22nd with a presentation, the sort of second half of our energy presentation, this one for more for businesses and buildings like that. So mark calendars for that. And then we've got other things in the works happening after that. Okay, so this morning, we have a really great presentation from Dr. David Willis and Kay Johnson on early relational health. We are going to be recording it, and we will post it to earlycareconnection.org in the next 24 hours. In the notes of that, the YouTube will be the presentation itself. So you can, of course, go there. You can share this out with folks if you want. And that's earlycareconnection.org. I'll put that in the chat in a few minutes. I'm going to first introduce Allison Logan, who is the lead consultant for the Connecticut Data Collaborative. She is going to moderate this and kind of do the work of interviewing and leading this presentation with Dr. Willis and with Ms. Johnson. So Allison, let me welcome you and thank you for being here.
Thank you, Izzy, so much. Happy New Year, everyone. I'm Allison Logan, lead consultant at the Connecticut Data Collaborative for the 3-year Pritzker Children's Initiative Prenatal to 3 Community Systems Grant. I know that's a lot. And also the co-founder of Connecticut CT359 alongside Dr. Janice Grindell. CT359 Network is thankful to the Connecticut Early Childhood Alliance for co-hosting with us today. We'll be joined this morning by 2 of CT359's national advisors, Dr. David Willis and Kate Johnson, who will take the lead on our grand rounds with a presentation on early relational health. After their presentation, we'll have a panel discussion partnering with the Connecticut Healthcare Center Association with Chief Strategy Officer Deb Poland and Amy Urban, Senior Director of Programs. Also joining the panel will be Meryl Gay from the Alliance. For those of you who are not familiar with the CT359 network, our mission of CT359 is to advance knowledge, build relationships, and help align efforts to assure that all Connecticut children are healthy and thriving at the ages of 3, 5, and 9. The timing of this grand rounds is especially important as CT359 will be releasing its 17-year look back to Connecticut's vision and progress for universal child well-being since 2006-2007. In that framework and investment plan, the 2006 Cabinet envisioned development of a much more robust relationship between the early care and education sectors and the developmental health sectors. As you listen to David and Kay's presentation, it'll be useful to reflect on how early relational health framework can help connect these 2 vital ecosystems for young children and their parents and caregivers. I'm going to now turn it over to Dr. David Willis and Kay Johnson, who will do an introduction of themselves. Welcome, David and Kay.
Thanks so much, Allison. Kay and I are delighted to be here. Kay, you want to say hello and introduce yourself, and then I will myself.
Sure. Hi, I'm Kate Johnson, and I am a maternal and child health policy expert over the past 40 years. Prior to my policy work, I actually was an early care and education provider in child care programs and early intervention programs for 8 years. I am here today as a consultant to the Nurture Connection Early Relational Health Movement, where I work on the policy team.
Thanks, Kay, a dear friend of mine, long-term, that are working together. And I'm David Willis, a pediatrician, developmental pediatrician. I think of myself as a developmentalist, all driving well-being. I've had the luxury of first being a clinician in Oregon for 30 years, focusing then in Oregon child health and developmental policy. Then had the amazing opportunity to lead the home visiting early childhood system work at HRSA, and then moved from there to the Perigee Fund as a funder in the Northwest to help promote social emotional development, and then now leading work at the Center for the Study of Social Policy to advance early relational health, and then what we've now called a Nurture Connection movement. And that's what we want to talk about today. But I'm really delighted to be with you all, especially in the context of Connecticut, where is the home for so many of the influences of my own long-term experience of development, not only with Paul Dorkin and Help Me Grow, certainly with the home visiting strength that I knew of Connecticut, including the good work of Darcy Lowell and the Child First model along the continuum, and then of course the work in Bridgeport. And Janice Grindell and I met when I was at HRSA, and this vision of alignment and long-term building of well-being in a life course view of building the foundation of well-being deeply with families and community has been so inspiring to me in all things that we've been doing. And so now that you've come to CT 359, I'm delighted to continue participation and learning about what we have been learning through early relational health and nurturing connection and how it's applicable to all things moving in your system building work between early care and education and the developmental health system. And that's what we're going to talk about today. I'm a developmentalist. You know, a baby's future starts really early. And the context of human development, we all have to focus ourselves on. We have learned so much far beyond just thinking about brain development and thinking about trauma and trauma-informed systems. And we've really come to a place where we're beginning to close that circle of understanding because it's all driven by that environment of relationships. So the last 2 decades have really focused on understanding about how does one build the health and well-being of children by the health and well-being of their families and the context. We've learned a lot, but we have to focus ever more intentionally about key drivers, not only the relational context early, but the relational context and well-being of the family themselves, because that generates the context of human developmental work done. And yet, we have many challenges in front of us, and all of you are aware this epidemic of mental health has an antecedent early. And I've been a long-term believer about preventative mental health and the criticalness of those positive, safe, stable, and nurturing relationships to build not only school readiness, kindergarten readiness, and preschool readiness, but also social emotional well-being. And social emotional well-being is one of our greatest challenges right now for our young children. And we know that the relational risks and the social health risks are unfortunately what disrupt the developmental well-being of children. And unfortunately, near 20% of children have mental, emotional, and behavioral conditions by the age of 5 to 7. So something happened developmentally. So me as a developmentalist, always asking, how can we build thriving and the well-being of all of our children? And I know you all in Connecticut are deeply focused on that moment and that opportunity and that elevation of this work. The other context we're keenly aware of is the hardships and challenges that so many families are facing. This work from the Rapid EC project of Stanford really has done representative sampling of families of children under 5 in terms of parent reporting their sense of well-being and the hardships in front of them. And you can notice they started during the period of COVID. And then when the child tax credit came in, you notice that parents' reporting of hardship dramatically decreased and held so until, unfortunately, the child tax credit was not reauthorized, at which point families started reporting ever more their difficulty and challenges day by day with food, housing, childcare services, and supports. And as the struggle with inflation came along ever further, that trend of hardship continues to really be the context within which so many of our young families are experiencing themselves, and that has relational consequences. The other startling reality is that parents are telling us in surveys, likewise, about their sense of loneliness and that sense of being disconnected. And in that survey that Capita did in North Carolina, it may be very similar in Connecticut, 40% of young parents were saying they were lonely compared to what has been in the past. And think about what loneliness means in terms of providing that safe, stable, positive, nurturing, and supportive experience. A single mom being alone is to me an emergency, requires that engagement. And our Surgeon General has been calling that out, this sense of the healing power of human connections in a lonely world as a driving element of a key strategy around building well-being and thriving in the next generation, which is really a call across all our country. And I know that in Connecticut, your Connecticut C359 is thinking deeply about those kind of elements. And we're bringing to you a mindset shift that strengthens ever more importantly the power of human connections. And we like to say that once you start thinking about relational health and you start thinking of the power of relationships to build well-being, you can't go back to thinking of the baby alone. You have to be focused on the well-being of every relationship because that's what weathers adversity. That's what helps build the well-being of the next generation. It is the driver of human development, is relationally and positive affective states, but it's actually by those simple, daily, ordinary interactions, those brief moments of connection, day in and day out, that make the difference in terms of building human development. We call that space early relational health. That's not a new concept, maybe a new term. It builds upon decades of knowledge and wisdom and practice within the fields of infant mental health, child development, neurodevelopment, but it really captures the wisdom that all people know. And it bridges and broadens the opportunities that promote those relational opportunities in early childhood. Let's be intentional. And if one starts really thinking about the experience of families with that isolation and loneliness, and the structures, systems, and policies that are not relationally centric, one starts seeing very quickly that the drivers of what we're all wrestling with in terms of building, thriving, and well-being are the disruptions or the disruptions of those relational contexts. That's the relational health frame. It applies to all things across all systems in all things that we do in terms of connectedness and being relational. Simply by definition, early relational health is that state of emotional well-being that grows between babies, toddlers, and their caregivers, all caregivers, supporting that strong, positive, and nurturing relationships. And it's within that movement that we're really focusing on that relational context of all and being mindful of how we are in the relationships with our youngest matters. It's that context that builds thriving and the well-being of the next generation, sets the trends of well-being. And it also is, one must has to think about this as actually dyadic or two-way nature between caregivers and children. And what's striking is that in that relational experience, there's benefit not only, of course, for an infant and young child, but also for the caregivers themselves. Caregivers benefit from being in those experiences with their youngest. In fact, some families will tell you, those both marginalized and struggling and challenged, that sometimes the most meaningful part of their day is that relational experience with that young one that brings them joy and meaning. And we have neuroscientific data that shows that the parent's brain actually heals itself too in those relational experiences, as it also happens. So this is a dyadic healing force that I would suggest to you is evolutionary and relationally built that we capture to help move forward in terms of the well-being. And what does it look like? I want you to focus your eyes on what's going on between them, that in-between space.
Uh-oh.
In the blink of an eye, you're a voyeur to the experience that you're witnessing between them. And I am certain that you find in your heart that sense of joy in the observational space between them of eye contact, shared affect, turn taking, that sense of pacing, that sense of knowing each other in this practiced experience. And we that are in the early childhood space witness these moments. This is that relational health space between them, and there's much going on that builds the well-being of the next generation in that relational moment itself. But it's also not just in the infancy period, but actually relational health moves into the developmental sequence. So one can see it in older age groups. I saw many of you have seen this wonderful little experience.
Okay. They need to work on that, right? Yes, okay. Did you understand it though? No.
I want to pause for a moment just to say to you, think about developmental skill development in the relational context. One can actually do a developmental assessment as one watches the interactive patterns. And the late Stan Greenspan taught us that relational development captures the developmental skills and processes. And it is in that interactive space one can look at development, as well as look at the affective drivers of building that cute little toddlers' developmental skills? What's happened?
Huh? Oh, no, not this one. This is the grand finale of this. Yeah, that's the last one. That's what I was wondering. I don't know what they're gonna do next season because they did some stuff this time. Exactly what I was thinking. Oh yeah. Right. Don't bring that again. You know what I'm saying? Don't do the same stuff. You know what I'm saying? Yeah, I was thinking that. Yeah. Yeah. Like go somewhere else with that, but don't bring it here. You know what I'm saying? Yeah.
Absolutely beautiful. And it's dyadic. They know each other. They have done this before. They are of one shared mind. They are experiencing the same moment and communicating with each other. And in a developmental sense, you see they have shared affect. You see that they have shared engagement. You see that they have shared turn taking. You see each one of them initiating an interaction with the other. You see each imitating the other. You see that they begin to have a nonverbal exchange of the same various shifting of emotional experience in that moment of whatever they're watching. In the developmental sequence, in the relational space, one can witness the developmental patterns between them over time. It is that synchronous interactive pattern that actually builds the human social capacity. And in every physiological system, and the neuroscience and the dyadic neuroscience is so compelling that one sees every physiological system is built in that interactive space, or not. Meaning stress regulation systems, the hormonal regulation systems, cortisol, serotonin, and the like. The brain's EEG patterns become entrained. That is, they imitate each other in development, and that's what tends to appear to develop the next generation's brain capacities. Language development happens in those interactive spaces, and then the concepts of humanity are passed by language from one generation to the next. That dyadic pattern and synchrony of human development is so critically important. What was thrilling 2 years ago, given all the good work that's been going, building beyond toxic stress, building beyond the early brain and child development work, was the movement where the AAP started to recognize that relational patterns and partnering with communities and families was essential for building well-being. And their first paragraph of this new policy statement, which was seminal and remains so as a call to action, talks about pediatric care as on the cusp of this paradigm shift, reprioritizing clinical activities, rewriting research agendas, and aligning collective advocacy. That was an accelerator of this partnering with families and communities in promoting the relational health, because it was moving beyond simply disease management. It was moving into promotion, prevention, and the continuum of support services, using the power of relational strengths to make change. And that has ever further elevated this concept of the high-performing medical home, which is moving towards a certainly redesigned child health visit that needs to be team-based with relational core coordination, as well as enhanced and co-located services, the articulation of a broadening team of medical providers and partners, of expanded team members, focused relationally with supports, knowing deeply the community, and then building that continuum of support services from positive strengthening and partnering with families on one hand, to identifying, screening, and promoting the needs of families to their social determinants, to then providing access to support services and intensive support services when necessary, that continuum with the medical home being a platform partnered with families becomes really essential as to this achieving a relational health context over time. There's already a lot of relational health work going on. And so again, it's not new, but it's accelerating and intentionally relationally. So of course, Reach and Read, which is a bedrock of promoting relational health, promoting literacy, has now adopted a relational health frame in terms of partnering to the strength of relationships to build literacy. The promoting first relationships work in pediatrics really sets the foundation of training about relationships really matter for pediatricians to partner with families. The keystones of child development that are now in most residency training programs across the country are focused upon how does one promote the relational context within families, calling out that high-performing medical home that's being advanced through the Healthy Steps model that I know is in many of your communities, as well as the Project Dulce, which is really upstream more intentionally in partnering with families. And then that effort to co-locate community health workers within the medical home, partnering with doulas in terms of alignment, that whole alignment towards building a larger team-based public health team of people with a relationally centric effort is already happening in these relational health in action. And I think in some of your communities, I'm certainly aware of that in Bridgeport, or that alignment of your multiple strategies, and many of your other communities putting these strategies together in terms of building that high-performing medical home partnered in the community with your caring community and the public health community really becomes a bedrock for really achieving and promoting this relational health frame. You got to have measurement here, though. One has to start thinking about how you knowing that all of these efforts are starting to make difference. You have to think of life course measurement strategies. So your 359 agenda to align data and learning together, not only of, can we start assuring that we're getting the connecting points we need, but can we set the platform of utilizing well-being measurements or other approaches to know that we're starting to demonstrate well-being outcomes as a result of relational frame. All of this has to be partnered in communities. So it's not a health system alone. It has to be partnered with families. Families as guide for more equitable supports and trusted relationship building, but also the connecting point between doulas and the health system and or the early care and education, knowing where to have access of services and supports, or the home visiting services, knowing how to be keenly available to the medical home, or the universal home visiting like Healthy Steps that can give not Healthy Family Connects, forgive me, as a universal touch point of partnering with families to their needs and access to services in the community. That linkage between early care and education and the development of medical home becomes really essential. And we're developing new models of promoting well-being that can be applied to the medical home, be that video interaction project, which is using video feedback to families, which has been recently by research demonstrating that even one reflective visit with video feedback to families can make improvements of a family's sense of awareness and sensitivity. Also, circle security parenting, the power of two, and then we certainly along that continuum, the Child First model, which is a relational health intervention, even for those families of highest need, can be attended to along that continuum of a relational frame. So that building a community of promotion, prevention, and then a continuum of support service by linkage, and then attending to the high needs of families becomes really important. We conceive of a strong relational health workforce that goes not only within the medical home, but also out of the community with community health workers, home visitors, planimetors, and doulas and navigators, all thinking about connection as a social determinant of health, assuring that all families are not isolated, alone, or lonely, but rather connected prenatally and forward becomes really important. And that partnership with families really matters. And how we partner with families matters of every system, and how we honor the wisdom and the strength of families and mindful of how we are with them becomes really important. And one of my colleagues shares a bit more about that kind of thought. I'm going to come to you. Your first impression.
It's so interesting that part of when you were just speaking, what I was hearing was coming to it around quality, but separating that quality from the quality of quality improvement. And so when I think about that, the two things that were going through my head were meaningfulness and mindfulness. So meaningful engagement with the family, with the parent, and with the child when they are in that appointment. And that engagement doesn't have to be for 15 minutes. Meaningful engagement can happen in small, minute pieces. And it can send a specific message to the parent and to the child about your level of caring. I think that's that empathy coming through, and that compassion coming through when you're doing your care, but also the mindfulness piece. I do think that when we think about things like implicit bias, and David, I hear you every time you speak talk about how pediatricians want to show up and how they want to do their work. And for me, understanding the medical system and how the healthcare system works, that does mean taking on the personal accountability for being anti-racist and working on yourself individually as a service provider, so that when you're in those moments, you are mindful and you are coming from a very different place. And especially because of the lack of time and how rushed doctors are and all of those things. I think the meaningfulness and the mindfulness together with that quality can make all the difference in that appointment that is always too short and never long enough.
So all of that, of course, matters in a health sector that's redesigning itself under the opportunity called by the policy statement, the opportunity from the science of relational experiences and relational health. But it all has to happen within the context of a system, a complex, and the health system is just a platform, but it's connected in families to so many other services and supports that really matter in local communities, from the early care and education system to the family support systems to the all the food, health, and mental health services and supports that are really essential of a system of care that helps connect to families and support those efforts, all built from a strength-based view, all building on the protective factors frameworks of parent resiliency, social connections, the knowledge of child development, all those concrete supports related to the social determinants, and all focus on those relational promotion efforts, but far beyond thinking about adversity in individuals, but thinking about the adverse environments to make it really difficult for families to be the successful people and have the well-being for the support of their families that really matters. It's not about fixing broken people. It's about fixing the systems that make it really difficult for families to thrive in the ways that they want. That's the challenge in front of us, likewise. And it's far beyond thinking about adversity and adverse childhood experience. It's really looking at how do we support positive childhood experiences because they mitigate adversity. How do we build those strong relational connections? Because that's the generational healing and opportunity of narrative and relational supports and growing over time. That's what we're capturing in our early relational health work that we've now called out as nurture connection, an effort to use all of these strategies to build healthier, more connected communities. And we have 6 major strategies of that good work: parent leadership, place-based agendas, multi-sector, cross-sector workforce, measurement research, policy advancement, messaging. You've actually captured all of that in your CT359 work in Connecticut. And a few of you have commented to me that your work in Connecticut is like Nurture Connection Connecticut. You're taking all these multiple strategies and moving that work forward. And our Nurture Connection network that we've built was launched in January. We have a shared leadership structure with a national steering committee, a core planning team, parent leadership in the center, and a large national network, many of whom within Connecticut are part of that good work. We've created a messaging guide that you can find on our website that is available for deep in your communities or in whatever sector you represent that help carry forth this early relational health messaging in your work. And for those communities that are really organized, you can actually create a mapping tool to explore these variations of what availabilities of needs are in your community that you can take particular action to. So before I talk about policy, I just want to summarize and state that early relational health really captures 3 key core elevator speech messages. One is everything's relational and it matters. 2, it really is about the ecosystem. Every system and support structures around young families is a part of the relational health frame. And then 3rd, relational health is always hopeful. It's about childhood experiences, thriving, resiliency, and those building efforts. So, Kay, let's talk about where we've come now about the policy and the opportunities that we've moved forward. To you.
So as part of the Nurture Connection work and the work of the early relational health hub, we've really spent the past couple of years looking at how what's the policy framework? What are the policy opportunities? What are things that we're talking about? Next slide, please, David. And we know that our nation has perpetuated economic, health, human services, and early childhood policies that don't support or don't promote early relationships between parents and young children. We have a more punitive approach to how our policies will deal with families rather than support them, and we know that we need change. Next slide, please. So the way that we started looking at this is that it's not a bill. It's not a policy. It's not one way to change. We don't have a bill that we want to introduce in state legislatures or a bill that we want to introduce in Congress, but rather that we see what it will take for families to have the opportunity to get those early relational health moments with their young children, is that the policies are grounded in equity, that they address economic security, that there's training for providers on early relational health, and that's across whether it's health or early care and education or home visitors or doulas, an array of providers, that there are services to promote early relational health, which David has shown you an array of approaches and opportunities that could be supported by policy, building that relational health workforce that is in the community, that is community health workers, that is doulas, that is home visitors, supporting high-performing medical homes. We have, national policy that talks about medical homes for children, and yet they don't follow our science, our evidence, and what we know families need. Having parent, infant, early childhood mental health be a priority, and those services funded, and whether it's consultation in a child care program or integrated behavioral and mental health in a pediatric primary care setting, and a continuum of other promotion and prevention opportunities, and then thinking about policies that promote early childhood systems, not address further segmentation. And that would include the array of other systems like child welfare and early care and education and so on. Next slide, please. We know that the federal policy today gives states broad authority to take action. So in many ways, states, and this has been said over and over again in United States public policy, that state leadership and policy action is what drives change in our country. And we know that it's happening with regard to early relational health. Last year, with Jeff Nagel, David and I undertook to learn and to get some examples of this state leadership and policy action. We have a new report that came out in December, and the link to that is in the slides. Next slide, please. So one of the ways that we look at this in this report is to put together a number of policies that we see as being direct and proximal to promoting early relational health. So again, thinking about that continuum of our policy agenda, what policies support economic security and equity, and things like paid family leave and minimum wage, earned income tax credit, child tax credit, and SNAP food support. And then parent, infant, early childhood mental health. These are findings from another survey we're using in this, the Prenatal 3 Policy Impact Center, as well as a number of other surveys and tracking systems to tell you how many states are doing what states are doing to promote high-performing medical homes, and there are policy examples. Our extended postpartum Medicaid is an example, or group prenatal and parenting, and Medicaid for doulas and community health workers. And then where's the funding coming for early childhood who got early childhood comprehensive systems grants or transforming pediatrics for early childhood grants? You can see these numbers vary widely. What you also might see in this slide is you're saying, well, where's home visiting? Where's childcare? Those are things where there is policy that sends money to every state. So these are things that really are only initiated by state action, where federal policy is not directly supporting all of these areas. Although the Medicaid dollars may be federal, only 10 states are using that money for doulas. Although we had the federal child tax credit, we don't have that refundable child tax credit that we had, and only 8 states have a child tax credit that would be an equivalent to that. So that's how you look at that. There's a nice table in the report, but that's the headline. Next slide, please. We also, in this report, take a deeper dive in looking at 6 states. New Jersey is the one that has the broadest initiative. It's actually calling the initiative Early Relational Health. It's thinking about how to strengthen systems. It's thinking about how to advance equity. It begins in the prenatal period. It's interagency. It's cross-sector. It has the First Lady of the state involved. It has an array of other state officials and public leaders and parents and families and foundations all pushing together towards similar goals. In the other states, we have initiatives that are not necessarily called early relational health. So in addition to saying we don't have one bill that we want everybody to adopt, it doesn't have to be called early relational health to be the thing that supports early relational health. So if we're advancing infant and early childhood mental health, that's supporting early relational health. If we're doing provider training and competencies related to early relational health, it doesn't have to be called that. In Vermont, we're using the high performing medical homes, using the Dulce model, trying to spread it statewide. We don't call it early relational health, but it clearly is early relational health in action. Next slide, please. So we think that every state can better leverage the array of policies and programs serving families with young children, and that this is absolutely a critical time to partner with families, providers, and communities to both advance equity and strengthen early relational health. We need effective policy advocacy and, of course, always strong implementation of those policies. And it's about reimagining and co-designing with families what the services and systems ought to be in order to respond to what families want and need. And for too long, of course, we haven't really asked families. David showed that little picture where things were very chaotic system to system, and we can do much better. Next slide, please. Just back one. Just a headline, this shows state paid family leave. It won't stay there. There's a slide that shows state paid family leave. For some reason, there it is. And the refundable tax credits in the darkest green, the states with paid family leave, including you with those little bubbles with stars. Of course, we still need Congress to go back and restore the child tax credit so that all families have that refundable tax credit. Next slide, please. I use just another map example of the extension of Medicaid postpartum coverage. So if every state would expand Medicaid postpartum coverage, or if Congress had adopted this, and you can see we're up to most states, then 2 million mother-baby pairs would have a full year of continuous health coverage, and that could be used to finance services that promote and prevent, particularly prevention of unnecessary health conditions and promoting early relational health. We can use Medicaid postpartum coverage combined with the baby coverage. It might be, and this map also shows the doula coverage. It might be community health worker coverage in a pairing up with that. But just the postpartum coverage itself, it's not enough for us to say we've extended that coverage. How are states going to make that coverage meaningful in terms of more promotion and prevention? Next slide, please. So we really, as David mentioned, think that a team-based, high-performing medical home is important, and we are really enthusiastic about the support for that in community health centers. And we think there's a huge opportunity in 2024, so that the HRSA Bureau of Primary Health Care has let early childhood development grants to 151 community health centers. The Maternal and Child Health Bureau has included technical assistance dollars, 20 to 3. David and I are part of that effort in designing how those health centers get some technical assistance. And we also, Nurture Connection, through David's efforts, has received foundation funding for a technical assistance and learning community project in a select number of states in probably about 15 community health centers, going deeper really into this. How can we build high-performing medical homes? Next slide, please. Those of you who are from the early care and education section, again, David showed this slide about the high-performing medical home. Again, the federal policy encourages, and the American Academy of Pediatrics defines that every child should have a medical home. And we have now, even for adults, the patient-centered medical home rules and certification, but they're so broad as to not really work for the young children. So David went through some of the details of this, but we need the well child visit redesigned. So it's about promotion and prevention, not just the immunization, not just listening to the heart and the lungs and seeing how the muscles are doing, but really looking at the family. Having there be relational care coordination. If you have a medical risk or a social risk, what's going on in care coordination today is not enough. And we think that community health workers and peer navigators and others can be the personnel to do that. And then we have a lot of models now designed to be co-located in that medical home. The integration of mental health, engaging families as partners, and then linking out to the array of other services. Next slide, please. So why health centers? And why are we so excited about this opportunity? That there are 3 million young children under age 6. It's 1 out of every 10 young children. It's 1 out of every 4 young children living in poverty who get their health care, their primary health care, from a community health center. And our thanks to the Geiger-Gibson program in community health at George Washington University. I was a part of the team that did this analysis. I also consult with them, but they're giving updates and data notes on these numbers. So in addition to that, the national data that we have show us that among the children, these are all children of all ages, up to age 18, cared for by health centers, but we're really looking at the developmental issue here. More than 600,000 showed signs of developmental delay. So the opportunity for serving, for prevention, for this to be the primary care for some of our most vulnerable children in our most underserved communities is right there before us. Next slide. So HRSA has done these early childhood development grants to strengthen the capabilities of the centers, to create strong partnerships with Medicaid, and to build and enhance relationships with other community services. This is about more than doing it, although we want that, doing the developmental screen and making a referral to Part C. This is about changing the way we do business in primary care and health centers for the youngest children and their families. It's a huge opportunity to move team-based high-performing medical homes. We know that there are exemplary sites across the country, and we're going to be writing about those in a report that hopefully will be out in the next month. And the sustainability for this really is dependent, we think, on Medicaid and its EPSTT child health benefit, and are working toward that as well. Next slide, please. The shovel-ready elements, and thanks to David for putting together, again, a set of things from the early relational health playbook that are ready for getting into clinical practice about promotion and engagement, about models to strengthen and support child development, about the relational care coordination, and about measurement tools. We have things that can be used today, probably more than anyone else center could or would want to use, but the things are shovel ready, so there's no need to do reinventing the wheel. Next slide, please. So I mentioned again, there's the funding to support early childhood development capacity. There are Medicaid opportunities for supporting team-based care, community health workers, developmental services, and Part C early intervention, and parent-child mental health therapies and early relational interventions. States have the Title V Maternal and Child Health Block Grant, which can support workforce development, quality improvement, family engagement, and other community-based services and supports. And there are funds that are being used now in select communities to transform pediatrics and early childhood, and we can learn from them in parallel to the work in health centers. I would note here this guide to leveraging Title V and Medicaid that's cited on this one gives a much longer view on how you might use Medicaid and Title V. Next slide, please. We think that the federal government has responsibilities. There's a Children's Interagency Coordinating Council now. We think that new joint guidance about the importance of serving families and the strengthening of early childhood comprehensive systems is important. In many states, there's a separation between their state advisory councils on the early childhood side or on the Head Start side and their early childhood comprehensive systems group, having those people work together, using home visiting as a focus for early relational health, and being sure that Part C early intervention programs have really fully addressed the social, emotional, mental development aspect of Part C early intervention, which is in federal law, but often underaddressed. The Medicaid to support the high-performing medical home and that parent-child dyadic care postpartum, training resources to Head Start, early Head Start, and childcare on ERH, the relational workforce, the Family First Prevention Services efforts to work upstream in child welfare, and other exemplary practices in income, nutrition, housing, and supports. Next slide. So just to come back around, maybe a little closer to what Bridgeport has done as such an exemplary spot for really community-based, community-driven action. David has written about equitable, family-centered, community-level early childhood systems. And what we know is that the system really is in a community that's on the ground where the services are delivered and the families live, so that there is parent leadership, that it is responsive and respectful, that it's really got a community-wide, place-based, population focus, that there's targeted universalism, in other words, reaching all children and families and focusing additionally on those who are marginalized or have special needs, and a continuum of services and supports from promotion and prevention to an array of interventions as families need them. Undergirding all of this, the first word up in the title of this slide about equitable, and having it be driving toward equity, not just measuring disparities at the end. So David, next slide, last slide, and back to you.
Thanks, Gay. And I'm certain that all of you can see yourselves and the opportunities within what we've been discussing, because this is an all-in strategy. Connecticut 359 is thinking about all-in strategies of multiple partners, leaders, and efforts around a vision. And so we'll look forward to a conversation. So Allison, can we come back to you?
Sure. Thank you for a wonderful presentation. That was so great. So great to hear everything. And yes, the slides will be sent out to everybody, so you will have access to the slides. I would like to now introduce Amy Urban and Deb Poland from the Connecticut Health Care Center Association. And I would love to, first of all, have you introduce yourselves. And then second of all, your reactions to the presentation from David and Kay today. Deb, we can start with you.
Great, thank you. And I am really excited to have heard what David and Kay shared around early relational health and how pediatric visits can be redesigned to promote that. My name is Deb Poland. I'm the Chief Strategy Officer at the Community Health Center Association of Connecticut. And our association works with the state's federally qualified health centers, or also called community health centers. And I'm happy to join you today and turn it over to my colleague, Amy Urban.
Morning, everyone. Thank you so much for including us today and for that amazing presentation. I can't help but think of my time working in community health centers and how great this work and collaboration would have been during my time in those centers to really integrate these services. So I'm very excited about that. As Deb mentioned, I'm Amy Urban. I am the Senior Director of Programs here at the Community Health Center Association of Connecticut. In my short time and tenure here, it's been a privilege to learn about these amazing partnerships and available resources in the community, and look forward to partnering with you all going forward.
Great. Thank you so much. So this question is going to be open for all. So anybody who would like to answer. And Meryl, thank you for joining our panel as well to get your insight. Do you have any reactions before I start with the questions around the presentation?
I know that this has been kind of heavy on the medical side. So for many of our childcare providers, thinking about those relationships between your staff and the children, but also relationships between your staff and parents. And just, I was really struck by the really high percentage of parents who felt lonely. And, you know, those very simple things of organizing social events at the center, a time when parents get to mingle with each other and get to make some friends of other parents with little kids their age, you know, the same age as their children, is something that when we're all stressed out by things is sometimes hard to forget. But those are important things to help build a network of parents so that parents have some support with each other.
Great. Thank you, Meryl. So this question is for everybody. So in bringing up the relationship between the child development sector and the pediatric sector and health sector with childcare, how specifically can an early relational health framework become embedded in workforce and professional development across various providers, whether it's healthcare or early care and education? Anybody can answer.
Well, I'll start. I mean, I think this is a great start. And I can see the wheels in Amy's head turning as she's sitting here. And one of the roles that we have here at the Community Health Center Association is to provide training to the providers out in our 17 community health centers across Connecticut. And I would really love for us to develop, along with David and Kay and some others, some curriculum around including these elements and the pediatric screenings.
I would add in there as well that I think community health centers are the perfect setting for this work to take place, as they're already sort of subject matter experts in social determinants of health screenings and connections to resources in the community, along with an integrated care approach where there is both the physical health component as well as the behavioral health component, with warm handoffs available right within the health center itself when a child presents with their caregiver, and some sort of anomaly is assessed and brought to the attention of the family. It gives that warm handoff opportunity. Of course, there's barriers to that with the available resources in the community and the number of trained providers that are capable of meeting the needs of the children and families. But it, like I said, it's a great platform for those care connections to be made.
I have been saying, with regard to this whole issue, and I reflect back on my years as a childcare provider, and what I thought I was doing is a lot of challenges have come up around this question, and people saying, well, isn't that just about health? And from my experience and my career, even working with an array of professionals, is sort of say, pediatricians think they have a responsibility to promote the well-being of young children, and their families. Childcare providers think they have a responsibility to promote the well-being of the children in their care. The doula feels a responsibility to promote the well-being of that pregnant woman and that new baby and that family. The community health worker is out there doing that work because they feel like they can make a difference in the well-being of the people who live in that community. People who work in Part C early intervention are in a niche with certain delivery of certain families, but they are certainly there to try to improve the well-being. And the more we've become sort of family-centered in that, think about those relationships in the family and how they promote the development of the child. So if we could get all those people to stop thinking they were the only one and see that they are all together in that job. And I think the training tools can really help. David, you can be more specific and clinical about this than I.
You know, and I feel very, very strongly about this, as do my colleagues in Connecticut, certainly Janice and Allison and so many others that know that activating informal systems for families really matters too. And that families connected with one another provides a network of support that's really essential. And that's quite frankly where families grow up. It's not the health systems of support, and it's not necessarily the service systems of intervention, which are essential, but it's also the informal systems that convey, we've got your back and your neighborhood support, and the community health workers and the churches and the other communities. We learn that in the Bridgeport work, where the activation of grandparents, the activation of churches, the activation of neighborhoods and communities, that's where public health and well-being live. And the rest of us have to be mindful of how we can be equitable and able to support families and listen deeply to their voices of what their necessities are, what they need and what they seek. And the movement that we've been witnessing around early relational health as it plays out in communities, the more we can learn from families as to what their needs are and how to best, what they say they need from us as a service delivery sector becomes really, really important. Mindful, though, that the sectors we have in place are already there. And we've been intentionally focused on workforce development, curricular development with the different sectors themselves, not only health system, be that Reach Out and Read, or be that the medical home and pediatrics, or the community health centers, in terms of building curricula for training, much like we've talked about here. But also we're now partnering with the community health workers in Washington State about educating them about their power of their relational role within that network of connecting families to counter isolation and to their needs into the community. Likewise, we have learned so much from the doula networks, and doulas themselves are a relational health support structure. They've been doing this for eons, meaning they know that the power of their relational connections is healing, supportive, and protective. And so much we can learn from them as they're part of this broader relational health workforce sector that can help us in communities for creating trusted connection and networks of relational support. Likewise, we're now deeper into the home visiting space. We're doing increasingly training through McVie, cross models. We're partnering now with some models in terms of advancing a reflective practice within home visiting. And we're about to start the QI work, parent-child interaction improvement through home visiting, targeted directly on relational health work. So this movement cross-sector about education, training, and development is really moving forward. But I can't emphasize enough the importance of listening deeply to the family experience and bringing the relational framing and nurture connections awareness with them. And you hear amazing things, like the sense of distrust of systems, like that sense of I'm being judged by all of the service sectors as to how I'm parenting. The sense of watch out, I don't want to be too honest with you because child welfare may well be knocking on my door. Let's be clear as to the systems that's been built that does not always support the trusted support for families. Listening deeply to their experience is that transformational relational health space that we have a lot to learn from, and your opportunity in Connecticut to elevate family experiences in your transformational processes becomes really important.
Thank you, David. This question is for Meryl specifically. Childcare in Connecticut and elsewhere faces a real crisis of survivability right now. And people in the sector and people maybe on this call right now may feel that they cannot focus on practice issues like early relational health and links to the health sector. In the midst of this crisis, what are the opportunities for us to be helpful here? And why do you think it's timely now?
So what we know about quality in early care is that it's about the relationship between caregivers and the children. And you can have a bright, shiny building, and that's wonderful, but that's not the determinant of quality. When programs are under stress, as many are now because they are having difficulty hiring staff, and in many cases not able to enroll at full capacity because they don't have the staff, it's really challenging. And what we know is that it takes time for folks to develop the skills to be good caregivers. To the extent that we have high turnover in the sector, that adds challenges to all of this. But as we deal with those challenges and we work on public policy to try and get some more funding to help stabilize the industry, we can't lose sight of that critical element of quality in care, which is developing those strong relationships between staff and children and families. So, I think this whole webinar is useful for us to think about how do we do things a little differently to make sure that we are focusing on building those relationships. The childcare market has always been broken. You've always had this system where programs have to operate with a wait list so that they can fill a vacancy right away. And therefore there's not enough supply. Families struggle to find care, and families struggle to pay for care. And that limits how much revenue programs have and how much they can pay their staff. And that has an impact on whether or not they can hire. That whole loop of mess there. That we're working on to try and address through public policy with the child care campaign, and that we work on in small ways to try and figure out, can we move this practice or this funding cycle to improve something. All of that those are the details, and we can't lose track of the bigger picture, which is this is about kids and families and the relationship between parents, between providers and children. That's the critical element of quality. And so,
Meryl, I love what you just said. That's so important. The other aspect of it that I feel, I was a person who spent, among my years in childcare, 4 years in a classroom with 18 2-year-olds and one other adult. And it was a 9-to-1 ratio for 2-year-olds in North Carolina when I worked there. I had a lot of energy when I was young. That worked for me. But I just think about moments, and I know everyone who's been a childcare provider has those moments where you say, oh, that family, or you say, oh, that child. And I think centering ourselves back in an early relational health frame, to say, where's the moment of joy I can find in this? How can I help this family build a stronger, closer, nurturing relationship with this child? How can I model it? How can I encourage it? How can I be the pathway for that to happen? How can I be the force and the energy for this young child that doesn't lead me to needing infant early childhood mental health consultation, or the family to needing therapy, although they may? But how do I get in there early and think in that relational framing?
Okay, I want to add in, and Meryl, I appreciate your words. I'm going to be a little provocative. Remember, I'm a developmentalist, okay? I'm a pediatrician. I've always thought about how do we build the well-being of the next generation? And we've lost track of multi-age group experiences. And I feel real strongly about the opportunity that one has to really, in this moment of crisis, reawakening some possibilities. And secondly, I want to add that within the childcare sector, as we all know, many of the families that are providing the services are struggling with the same forces that make it difficult for families themselves. So how do we bring reflective practices on one hand, so the providers themselves can reflect on their own experiences to healing and recovery, part one. Part two, until we as a collective society, maybe Connecticut is an opportunity, to see that relational health outcomes, the things we care about deeply, are about the whole care system, not just parents, but also the early care and education head start, early head start, that whole provider care system, which has been disenfranchised and worse, stressed. And if you really look at the science deeply to the childcare experience and the outcome related to childcare experiences, you start seeing that the forces in childcare in terms of outcomes are the same forces that families are experiencing: poverty, depression, anxiety, isolation. And then I would add another element, which is single age group groupings. 4 babies to 1 caregiver by policy still is insufficient for me. And that's controversial, I realize. But multi-age group environments, there's a natural healing force that happens with children with one another, so that the one caregiver isn't raising 9-to-1 kids. Think about the natural developmental processes that go on relationally and social relationally that we've lost track of in policy. We need innovations. We need research efforts. We need opportunities to consider new things. We need to be thinking about the power of family, friend, and neighbor community childcare. We've got to really reawaken our considerations around this space. And crises are opportunities. And so I challenge Connecticut and others to be thinking about those kind of learning possibilities for well-being outcomes that are relationally centric.
Thank you, David. Go ahead, Meryl.
I'm struck as David was talking about one of our earlier guests, Walter Gilliam, talking about the long-term study he's been involved with that started during the pandemic, looking at caregivers and just the high levels of stress and burnout and depression among early educators. And I am, always remember the time when someone called me asking for help identifying some folks who had were at risk of losing healthcare when the state was talking about reducing eligibility for the state Medicaid system. And I put a message out on our listserv asking providers to, help find some of their parents who might be experiencing this issue. And within about 5 minutes, I got a message back from a childcare director saying, "That's me. I'm the person who's about to lose my healthcare because of this change." And that was a good reminder to me about how little so many childcare providers and childcare directors actually earn. Changing from 180 to 150% of state median income, or no, of the federal poverty line, was going to impact a center director. So just that whole notion of, if we want to improve the quality of care, we need to pay attention to the situation of the caregivers. The number of times I've talked to providers who say, "Oh yes, and I work a second job so that I can pay my rent." That is just that's a real shame that for this country that we put providers in that situation.
So if we really care that flourishing and well-being is driven by the relational contexts that every young child in Connecticut is experiencing by caregivers, we cannot ignore the crisis experience of the caregivers that are by and large childcare providers. Let's be clear.
Yeah.
We can't blame parents for the struggle that children are having in their outcome when they're working and their children are in childcare quality and they're really struggling themselves. Let's be intentional by the science and the knowledge, and then figure out how we adapt the policies to the current moment of relational drivers for well-being outcomes.
Thank you. So this is for all. We have 15 minutes left. So I figure hopefully everybody can speak on this, since families are in the center of all of this work, and family relationships and relationships between children and families, and healthcare sectors and early care and education sectors and families. So family engagement in both early care and education and pediatrics is the key to young children's health and development. What are the greatest barriers and opportunities to become full partners with parents in this work. So I'll let everybody speak on the panel, and you can answer that question about how to become full partners with parents, and then any closing thoughts. So Deb, we'll start with you.
Sure, thank you. And I think Amy mentioned this. I mean, we think community health centers are the exact right place for this type of work to happen, because remember that kids and their parents and grandparents can all be getting services under the same roof. There's also behavioral health, there's dental, there's a lot of wraparound services as well. And everybody can be treated regardless of ability to pay, immigration status, insurance status, et cetera. And we also have school-based health centers. So this care can be carried forward into a school setting, which is very convenient, obviously, for families, and also for the children, and to create those relationships with the educators as well. So all of the elements are in place to make this successful. And so you're wondering, what's the barrier? One barrier, and just to bring it down, is payment. The way that health centers are paid, it's the same payment for every medical visit, regardless of whether it's a quick in and out, think my kid has an ear infection, or whether it's a full well visit, or whether it's a 5-hour autism diagnosis. It's still the same exact payment. And that does present some opportunities, but also in this case, some challenges. Without getting additional payment for things like the community health workers that health centers do have on staff, patient navigators, interpreters, and other support staff, we do end up relying on these durational grants, like the one that was mentioned earlier, the HRSA grant. It's a fabulous opportunity. What happens when it ends, we're not sure. So it is, I hate to make it about the money, but it is partially about the funding and the financing mechanisms in order to make this successful and scalable.
Thank you, Deb. Amy, any thoughts?
Yeah, thank you, Deb. I'll add as well that workforce is a barrier, that we have a shortage of pediatric providers across the state, and we have even fewer that are subject matter experts in areas like trauma-informed care and some of these other specialties that you've mentioned. So that's been a challenge. Having the time and resources to be able to conduct those longer visits is a challenge, as clinics are bustling, and we have folks that may not even schedule appointments, that just walk in with an urgent need. And so that puts a burden on the providers to make priorities around, am I seeing what's in front of me today and treating what I'm capable of treating in that short 20-minute time frame? Or do I invest the time as I've discovered this challenge or barrier or resource need for these families? We also have issues across the state in terms of transportation for folks that don't have their own, and making sure that they have the time and resources to get into the health centers. We also have, I would say, another significant barrier for our parents is health literacy. And we ask them to constantly prioritize, am I worried about getting food on the table today? Or am I worried about making sure my kid is getting to school? Or am I worried about making sure that my kid has had all of their immunizations according to a time frame? And they're not necessarily prioritizing some of these less talked about things like developmental screenings. And how do we normalize that conversation? How do we get in front of that during that prenatal period to establish that as a framework for parenting of, here are some things to be looking out for, and here are some available resources in your community. So I would say those areas are some barriers to promotion of this model. I will say that technology is working in our favor a little bit here, in that most of the electronic medical records within the health center environments do have these embedded screenings in them. And so it's an opportunity for us to use those screenings to help inform the outcomes and what the appropriate referral sources are. And some of the health centers that have received this funding have already adopted some creative strategies to give parents the opportunity to have those screenings done in advance of the visit. So how can we have them use technology like a patient portal to answer some questions that may help inform the provider, so that during that limited time frame that they have with the patient, they're able to address and uncover more of what's going on developmentally. So not having the available funding to pay for that technology is also a barrier, because then there's inequities from provider to provider. And standardizing that approach would be very, very beneficial. Those are my thoughts.
Thank you, Amy. Meryl?
So there are a number of things that I'm thinking about here. One is that the work of the Blue Ribbon Panel that has just concluded really focused on the provision of care and not on the stuff that we've talked about today. And you know, in a way, the fact that the childcare industry is in crisis, that we have hundreds of closed classrooms right now because the workforce shortage is so great, that, you know, we're looking at roughly 4,000 staff vacancies within childcare. And, you know, the things like the increase in the minimum wage from $15 to $15.69 is something that impacts childcare much more than other industries, because, you know, in an infant toddler room, that wage increase is shared by four parents, four customers, as opposed to, you know, at the coffee shop where it might be 100 different cups of coffee that are bearing that added cost. And yet it's, you know, horrible that we're talking about minimum wage as a factor in compensation for early educators. But we have a very low wage sector because customers can't bear the cost. We need to be thinking about this from a public policy perspective. That early slide that David showed of the stress levels on parents and how it changed when the federal refundable child tax credit came in. That's a clear sign of how public policy can have an impact on the work that we're doing. Early educators have always felt like we're kind of at the bottom of the heap, and we're masters of figuring out how to do it with what we've got. You know, you go and you look at the creative things that early educators do with things the rest of us would look up at as, you know, stuff to be thrown away, as, you know, those cardboard tubes and, you know, toilet paper tubes, etc., that we managed to figure out what to do with little kids. That's the sign of the, you know, the reality of doing with what you have. But we need to think outside of that sort of day-to-day imperative to think about what is the change that needs to happen, and how do we persuade policymakers that this is a critically important thing that needs to be addressed? That the future of society is based on the mental health of the kids that we're dealing with now. That there's a whole lot of stuff that is slowly accumulating as, you know, weight on society, because we have not addressed these things. And, you know, we need to think about how do we get policymakers to really focus on this.
Thank you, Meryl. Kay, last thoughts?
I guess I think it's just building on particularly what Meryl has said is, you know, how do we, I'm going to go back to the point you were making originally, Allison, which is engaging families. And engaging families in a conversation about how public policy can change their lives and why it matters. I grew up in a very low income family. I happened to have a family that had a little bit of political consciousness, you know, but they really didn't know what the macro policies were that were driving. How do we translate that public policy agenda into something that's meaningful for families? Because if we translate it well, they absolutely will be allies in changing the political mood. They can be allies in changing the policies themselves, and they can be allies in changing the systems. But we have to listen and learn with them, and do, you know, joint thinking with them. We're just not very good at it.
Thanks, Kay.
Yeah, I talked about how childcare providers tend to, you know, focus on the, you know, how do I make do with what I've got? Likewise, parents, when struggling with childcare, tend to focus on the how do I get my need met most quickly, which is like, I call my mom or I call my sister, can you cover childcare? Because my, I don't have a slot right now. And a recent conversation I had with a state senator who said, I don't ever get phone calls about childcare. Right now, my inbox is full of letters from people who don't want to have to buy an electric car in 12 years. We need to change that. We all know a dozen people who have struggled with childcare, but converting that into the political movement to change the system that's where we need to move to.
Thanks, Meryl. David, final
Yeah,
thought.
I agree with every one of the gaps that have been mentioned, as well as the barriers. And I'll go back to the original question, full participation with parents, which means valuing and respecting their experience. And they'll be telling us about, what are you going to do about my childcare needs and my income needs? And until we really embrace that, as Meryl, you're talking about, Kay mentioned, we in all systems care about, until we really elevate that as a core value, and that everything we do is in the service of the well-being of families, which is thereby for the well-being of the next generation of children. And we're not doing that. We got to be intentionally calling that out. So partnering with families and listening deeply. And I think that's hyper-local. So again, while I loved the Bridgeport work, which where families were guiding what their needs were, and then how systems, formal and informal, can come to fill in and support and surround. That's a key learning, I think, from the Connecticut leadership work. And ever more, full participation of parents also means respecting what they say with actually embracing it as truth. Then looking at barriers. And if you look at the relational health, once you cross into the relational health frame, you realize the disruptions to relational health that we just take for granted, or worse, we put it into deep policy, or worse, we're not allowing any movement of change. And until that gets embraced, we're going to have the same outcomes and worse of the children that we all wish were something different. It starts so early, prenatally, at the level of the perinatal experience and then that postnatal experience. And then those first 300 days, 500 days, development of well-being, those regulatory systems that build learning, emotional regulation, social engagement, collectivity, participation, it happens so early. We're all lamenting about until basically we listen to what all families know about their full participation of need and their hearts of what they know is best for themselves and their children, and how we don't allow that to happen well is staring at us. Those are the politically important messages.
And I just add in too, when you mentioned that, David, it made me think about the health profession training programs in our state and how we really need to think about the next generation of providers and ensuring that as they're being trained, they're being taught about principles of equity and valuing the patient's experience, the family's experience, and helping to guide conversations during any medical visit, and bringing this into all the early relational health information into the training programs, I think would make a wonderful difference in how new providers come in.
So great. It's a mindset shift. Every system we have in early childhood, except for childcare, Head Start, is focused on fixing broken people, not about building their thriving capacities. And when you absorb that perspective, you see an opportunity for change that is begging. And that's Connecticut's opportunity, Connecticut 359. You have a vision of thriving children. Ask those disruptive questions about what the opportunities are in front of you, which is very, very, very opportunity important now.
Thank
Allison,
you. Janice, I'm going to give you a last word.
I just want to say how stunning this has been and how incredibly honest this conversation has been. I am incredibly grateful for that. The last word should go to the nearly 200, in fact, a little more than that, people who listened through this with us and shared their comments. I see great hope in that. We had 200 people. They didn't drop off to 10 people. You all stayed. So I thank the panelists and also everyone who listened. Let's figure out together how we can get this amazing conversation to you, to your staffs, to state agencies. We could use your help and we would welcome it. Thank you.
Okay. And I'll just sort of close us out, unless you have something else you wanted to say, Allison?
Nope, I just wanted to thank everybody for
Okay.
their amazing participation today.
All right. So as we come to the end of our hour and a half, I just wanted to remind everybody that we will not have a webinar next Monday because of the holiday, but we will be back on the 22nd. And I think that our topic will be the second half of our conversation about energy efficiency and supports for childcare, particularly centers this time, on ways that you can access funds to make your program more energy efficient and save money that you need to use to pay your staff, etc. So see you in 2 weeks. Thank you, everybody.
Everyone.
Thank you so much.
Hi, everybody. Thank you.